Today we'll be talking about myringotomy. Myringotomy is a surgical procedure in which a tiny incision is made into the tympanic membrane to relieve pressure due to fluid buildup. Anatomy and physiology is as follows. The external ear, or outer surface, includes the tympanic membrane, auricle, external auditory meatus, and external auditory canal. The auricle is a cartilaginous area covered by the skin, and its function is to gather sound waves. The center of the auricle contains the auditory meatus and external auditory canal. The lateral third of the external auditory canal is surrounded with cartilage and are lined with glands that secrete cerumen, or a waxy substance. The external auditory canal is 1 inch or 2.5 centimeters and terminates at the tympanic membrane. The tympanic membrane is a barrier between the external and middle ear. The middle ear contains the tympanic membrane, which is a medial wall of the middle ear cleft. The middle ear contains the tympanic membrane, ossicles, which are the malleus, stapes, and incus, opening to the eustachian tube, opening of the mastoid cavity, and the intratympanic portion of the facial nerve. The tympanic membrane is elliptical and conical in shape and aids in the hearing process by transmitting sound waves to the posterior ossicles. The 3 ossicles can fit on a dime. The malleus or hammer bone is most lateral and partly embedded into the tympanic membrane. The incus or anvil connects stapes to the malleus. The stapes or stirrup transmits vibrations of the tympanic membrane or other ossicles to the inner ear by the oval window. The proximal eustachian tube is composed of connective tissue and are lined with mucous membranes. It extends into the nasopharynx at its distal end and assists in equalizing pressure between the external environment and middle ear. The pathway for bacteria to spread is from the nasopharynx to the inner ear, causing otitis media or middle ear infection. The inner ear includes receptors for hearing and balance and is composed of a series of hollow tunnels called labyrinths. 2 separate labyrinths include the bony and membranous. The bony labyrinth is formed by the temporal bone and is filled with perilymph fluid. The membranous labyrinth is within the bony labyrinth and has 3 parts: the cochlea, semicircular canals, and vestibule. The cochlea is spiral-shaped and contains cochlear duct and the organ of hearing, which is known as the organ of Corti. The organ extends along the length of the membranous labyrinth and the cochlea. The organ of Corti is lined with cilia, which is designed to project into the endolymph and receive sound waves transmitted by the middle ear. The semicircular canals communicate with the middle ear via the oval and round windows. It is located within the temporal bone and contains endolymph. Each canal contains an enlarged space called the ampulla. The crista ampullaris is located within the ampulla and is responsible for equilibrium of the body in motion called dynamic equilibrium. Hearing is the neural interpretation of sound transmission. Sound waves enter the ear and are transmitted to the tympanic membrane. The tympanic membrane vibrates against the malleus on the posterior side. The vibration enters the incus and stapes and connects to the oval window. Sound is transmitted into the perilymph of the cochlea, vestibular membrane, and basilar membrane of the organ of Corti. Sound transmission occurs from the basilar membrane to the cochlear nerve. Indications of myringotomy include effusion, which is a buildup of fluid in the middle ear caused by inflammation of the mucosa. Eustachian tube dysfunction happens when airflow between the nasopharynx and middle ear is inadequate, resulting in negative pressure in the middle ear and retraction of the tympanic membrane. This can be caused by a congenital anomaly, nasal mucosa inflammation, or enlarged adenoids. If left untreated, it can lead to infection, mastoiditis, hearing loss, or perforation. Diagnostic tests include clinical examination of the external auditory canal, auricle, and surrounding tissues for signs of infection, inflammation, neoplasm, scars, or lesions. Otoscope is performed for the initial examination of the tympanic membrane. Cerumen is removed as necessary to allow complete visualization of the tympanic membrane. If microscopic examination is used, it is performed with a 250 mm lens and ear speculum. CT and MRI are used for abnormalities like asymmetrical hearing loss, nasopharynx mass, oropharynx, ear, or cholesteatoma or infection are suspected. Patients will be under general or local anesthesia. Children will be under general, and most of the time local is used for adults. The patient will be in supine position with a donut headrest. Skin prep is usually omitted, but if used, it will begin by putting a cotton ball in the ear to prevent pulling. Prep will begin at the auricle and work outward into the periocular skin. Pulling under the neck is prevented. Draping is also usually omitted, but if it is used, 3 folded towels are placed around the ear and a U or split sheet are applied. Sterile handles are available for the microscope if used. Incision is made into the tympanic membrane with a myringotomy knife. Supplies include a small basin, warm saline, bulb syringe, suction tubing, myringotomy knife, myringotomy tubes, cotton balls, and microscope. Equipment includes padded foam or gel headrest, padded upper extremity restraints, suction, fiber optic otoscope or microscope, and sitting stools. Instrumentation includes a myringotomy tray and hand grips for the microscope. Procedure includes a small incision is made into the tympanic membrane. This will allow equalization of the pressure between the middle ear and outside barometric pressure. The tubes will be left in place until they fall out. The surgeon will sit and use a microscope with a 250 mm lens. The surgeon will insert a farrier speculum into the external ear canal. Size will depend on diameter and depth of the ear canal. Any wax or debris are removed from the external auditory canal with a cerumen curette. A 2 to 3 mm incision is made into the tympanic membrane with a myringotomy knife. Fluid from behind the tympanic membrane is suctioned with a small Fraser microsuction. If tympanoplasty tube is to be implanted, it is grabbed with an alligator forceps. The tube is inserted into the incision. A rosin needle is used to seat the tube into the incision. Antibiotic and steroid drop combo, or just antibiotic drops, are instilled into the external canal. The speculum is removed and the external canal is packed with cotton. There will be no specimen, and the wound classification is clean.